Hello, my name's Ian McComb. Today we're going to have a little look at seborrhoeic keratoses, both the clinical features, the dermatoscopy, and a little bit on histopathology. Let's have a look at the seborrhoeic keratoses here. They have a very warty appearance, hyperkeratotic. They often extend into the scalp margins, seen at the scalp edges, particularly also seen in the back. Now, they have a greasy, stuck-on appearance as well. Let's have a look at this. There's your more typical back with multiple seborrhoeic keratoses, varying in color. Some may be pink, some may be quite dark. Multiple eruptive seborrhoeic keratoses can occur over a short period of time as the sign of lesser trelat, and this is when there's an association with an internal malignancy, particularly stomach or lung. But the vast majority of people acquire these lesions not because of sun exposure, because of genetics. There's usually one or other parent who's got multiple seborrhoeic keratoses. Women often get them under the breast, where they're a particular nuisance. You can see how thick these lesions are here. A couple of other pictures. There's a very typical seborrhoeic keratosis. The stuck-on material as well. There's no real depth to these, and this will be reflected in the histopathology. You can often peel off parts of the superficial crust here. Some of them, though, can be quite thick, and they can be quite dark as well with all this thick build-up of keratin. See the various sizes, though, of seb case that this patient has. Sometimes you have a verrucous seborrhoeic keratosis, very wart-like. Many of these are showing that in this particular patient. Other times, though, a seborrhoeic keratosis can be relatively flat. Usually, if you take a fingernail over it, you will feel the slightly raised surface here because it's a tumor of keratinocytes in the epidermis. There's hyperplasia, there's acanthosis, or thickening of the stratum corneum. This was the dermatoscopy of that particular case. There isn't really any sign of a pigment network there. You can get pigment networks in seborrhoeic keratoses, but there isn't in this particular specimen here. You're also looking for little milium cysts, and we'll see these in the dermatoscopy of some other lesions. Here's another one on the leg, slightly more raised, fairly uniform color. And if you have a little look at the dermatoscopy of that, though, you'll see these various crypts, almost having like the surface of the brain, crypts and gyri. So this is a very typical dermatoscopic image of a seborrhoeic keratosis. These are invaginations in the surface of the epidermis filled with layers of keratin. This was another lesion that a plastic surgeon was going to remove on this gentleman's arm, but of course you put a dermatoscope on it and look at it. You can see it's a series of brown clods here, and this was all a seborrhoeic keratosis. It was quite rough on the surface as well. This is what's called an irritated seborrhoeic keratosis. They're often slightly more vascular, slightly pinker. They may bleed easily. You can see the small points of hemorrhage on the surface of this in amongst all this keratin. And it can sometimes be difficult to distinguish this, an irritated seborrhoeic keratosis, from a squamous cell carcinoma. And so often you have to shave these for the histology. This was just another example of that brain-like pattern that I was talking about in some seb case. There's your more typical dermatoscopic appearance of a seborrhoeic keratosis. These are orange clods made up of keratin in some of the crypts. Sometimes they're dark brown as well. These are the intraepidermal collections of keratin, the little milium white clods, the milium cysts. So you can get a mixture of keratin. Can be white, can be orange, can be dark brown, depending on where it is. This one was just to compare and contrast a seborrhoeic keratosis occurring adjacent to a basal cell skin cancer, or pigmented BCC. Here you can see the brown clods made up of the proliferating cells of the basal there in the dermis, with melanin in them giving the bluey color. There's the very sharp serpentine vessels that you typically see in a basal cell skin cancer. And against that are the orange, the white, and the brown clods, where crypts are filled with keratin on the surface of this seborrhoeic keratosis. Just a close-up again of a SEBK showing these various features. Here's one behind the knee. In fact, I think this was the clinical of this. There's some histology here, but we'll go into this in a little bit more detail later. There's sometimes some excess pigmentation. This is called a clonal seborrhoeic keratosis. It's called a clonal SEBK because you've got a group of cells here that are different from the other epithelial cells. And this is called the Borch-Jadison phenomenon, or the Borch-Jadison phenomenon, I should say. But it's part of a clonal SEBK. No major clinical consideration. What else do we have? Yeah, this was another irritated seborrhoeic keratosis. You know, they're pinkish, and they have a fair sprinkling of vessels through them. You may look at these. There's often looped vessels, as you would see in an SCC, but you'll see them also in a swelling, irritated seborrhoeic keratosis. Sometimes SEBKs can be very dark, as in this particular one here. And if you look at this, there's the dermatoscopy, exceptionally dark. When you look a little bit closer, you even get bluey shades in here, because this is a very thick lesion, and so there's also a lot of melanin in the keratinocytes here. This is a keratinocytic lesion, and it's blue like this because of the thickness of the epidermis here. Normally you associate the blue color with melanin pigment in the dermis, but if you've got a really thick epidermis like this, then you'll get a bluey shade to seborrhoeic keratosis as well. This is a very flat variant of a seborrhoeic keratosis. You can see it's already been biopsied here. And sometimes this will be reported as a large cell acanthoma. Now, acanthosis just means thickening of the epidermis. The cells in a large cell acanthoma, the keratinocytes, are larger, and it's just given this name of large cell acanthoma, but it's just a variant of a seborrhoeic keratosis. We've got a couple of others here. There was this rather dark one. This was the dermatoscopic view. Again, you can see some of the looped vessels here, all surrounded by keratin. There's not a lot of pigment in this, so of course you get this pinkish color. There are a few other variants that we'll talk about a little bit later. I'll come back to these. Let's have a little look at the histopathology. And for this, I'm going to go to this particular website here. This is the Atlas Mundi. Let's look at an acanthotic seborrhoeic keratosis. There we go. Acanthosis just means thickening of the epidermis here. Look at the way this is just stuck on the epidermis. Okay, there's your edges there. It's just stuck on. You take a piece of string across here, and all the lesion would be above it. Some of these, this is keratin-lined cysts, and these open out into the surface here. They're not true cysts because of the openings that they have. Some of these will appear white. Some, if they're close to the surface like this, will appear brown or orange with the keratin in them. So this corresponds to those orange and brown clods that we saw earlier on. Let's have a look at a couple of others. Here's a clonal seborrhoeic keratosis. You remember we talked about that Borch-Jadison phenomenon? Let's have a look at this one. It takes a little while to load sometime depending on the size of the image itself. So bear with me while it reveals. Now, in a clonal seborrhoeic keratosis, we said there were going to be different, little different populations of cells. I'm looking at these cells here, these lighter cells here, as being the clones. Sometimes there's glycogen in these, and that's what gives them that lighter color. This has a sort of reticulated pattern as well. This is all thick keratin on the surface of this lesion. There's possibly a little bit of bleeding into this as well with that orange color. This is all intraepidermal. Here there's a lot of inflammatory reaction. So this is an inflamed clonal seborrhoeic keratosis. What other ones do they have? They're saying this is an irritated seborrhoeic keratosis. Remember that was the one that was pinkish. Should be a lot of lymphocytes there. Shouldn't be a lot of color. Let's see what it shows. Okay, I think there's, to me, there's a clonal element to this as well. These cells are different from these cells here. It's all within the epidermis, thick keratin on the surface, relating to the clinical appearance of these lesions. Bit of inflammation with lymphocytes and the like here. So, an irritated seborrhoeic keratosis. People often get worried with these because they've had a relatively flat lesion that suddenly becomes pink, irritated, and they wonder what's going on. What other variants have they got? Here's their version of a reticulated seborrhoeic keratosis. Let's have a look at it. Yeah. There's the reticulated pattern here that they talk about, all these strands of cells. And again, you've got little cysts, keratin-lined cysts, squamous-lined keratinous cysts here, some opening onto the surface. These would be crypts, these would be milia. This is a bit inflamed as well. Got another one here called a melanoacanthoma, a really deeply pigmented seborrhoeic keratosis. Well, we showed you one of those when we were looking at the clinical earlier on. Let's take a look at this. Make this just a little bit bigger. Okay. Now you can see the pigment that's in this. This is what would make this very black. I'll show you an example in the clinical section in just a minute. But all this pigment is in the keratinocytes. And so this would be an exceptionally dark seborrhoeic keratosis. If this was thick enough and this pigment was deep enough here, it may even give a bluish color, as we showed in one of the specimens earlier on. So let's just flick back to the clinic, to the images before. Here was my example of a melanoacanthoma. Look how dark that is. If you actually look at this, there's a lot of pigmented, there's a lot of dendritic melanocytes in amongst these cells, these epidermal cells here, and they're putting a lot of pigment into them. This is why it's as black as it is. And if you look at the dermatoscopy of this, you can see how dark this is, and how, you know, to the uninitiated, you might think that this is a melanoma. But you see the edges here. You know, there are no clones of, there are no nests of melanocytes growing out here. There are no pseudopods. There are no lines radial peripheral. These are some crypts here with a lot of keratin, dark keratin material, and a lot of cells with melanin in it as well. What else did we have? Yeah, it's another clinical variant of seborrhoeic keratosis you should know about, and that's dermatosis papulosa nigra, often seen in people of Asian origin. Look at these little lesions here, just tiny miniature seborrhoeic keratoses. you just have to be careful. You're going to try and treat these with liquid nitrogen because you might hypopigment the skin. You can take a hyfricator and just gently cook these and they'll just wipe away. Or you can take a CO2 laser and gently treat them as well. But histologically, these will just show the acanthosis, the hyperkeratosis, the features of a seborrhoeic keratosis. What other examples do we have for you here? This was just a guy's scalp. Always look carefully here because, though this is quite warty on the surface, there just may be a lentigo maligna stuck in there as well. It's not uncommon to get lentigo maligna with seborrhoeic keratoses intermingled with it, especially in a sun-damaged skin like this. Now, there are a couple of other things that are really variants of seborrhoeic keratoses that I want to show you as well. And one is the clear cell acanthoma. So let's have a little look at it. Clinically, this is a clear cell acanthoma. They're usually pink lesions like this, usually on the flank of the lower legs. And if you look at them, you'll see these dots, red dots and lines, typical feature of a clear cell acanthoma. It's a very distinctive dermatoscopic picture, this. These things are seen in all age groups. Particularly, though, they're seen in people in their late 50s and onwards. And they may be mistaken for some other pink lesions, such as amelanotic melanoma. But the dermatoscopic view really should tell you what they are. Now, back to the histopathology here. I think we've looked at most. There was their melanoacanthoma. Have they got an example? No. There's dermatosis papulosa nigra. They've got a clinical, but they don't have a histology there. They're commenting, shallow acanthosis, interconnecting retty ridges, hyperpigmentation of the basal layer, keratinous cysts, invaginations. So similar to a reticulate seb-K that we showed you earlier on. Okay, well, I think those were most of the variants of seborrhoeic keratosis that I wanted to look at histologically and to chat to you about clinically. They're always interesting lesions, these. You'll be amazed just how much variation there actually is in them. And it's so easy sometimes to mistake them for a early lentigo maligna. But once you get your eye in with your dermatoscope, you should soon be able to pick the difference between the two. We'll do lentigo maligna at a different time. Thank you very much.